All right, folks, let's start. We're getting back to some immunology now. The previous sessions were all dealing with the immune response, the normal immune response, how we make antibodies, B cells, T cells, and so on. And the next part of this course is what goes wrong with the immune response. This wonderful thing that we told you about, production of antibodies, cell-mediated immunity, causes us a lot of problems under certain circumstances. But before I do that, I want to explain to you that we told you how you activate the immune response. You make antibodies or cell-mediated immunity, CD4 cell doubling and tripling and all this sort of thing. You realize you have to turn down the immune response at some point, okay? It's okay to make an antibody against a streptococcus, but you've got to turn it down. The antibody go up and up, you know, you become a lump of antibody. You've got to turn it down. So we have mechanisms to control the immune response, and that's what I want to tell you about first of all. So here I'm just showing you how immune responses, this could be to a strep or anything, go up, antibodies, and then down. This could also be a cell-mediated immune response. Look, the number of antigen-specific T cells. This could be, let's say, an invasion by Candida albicans, you see? And now your T cells get activated, and they divide and divide and divide, IL-2 and IL-2 receptor, and then a point comes where you have to turn it down, and the majority of those cells disappear, leaving you just with a few cells in your memory, you see? That's why if you've been exposed to tuberculosis 10 years ago, you know, you made a beautiful immune response and then it settled down, but you still have a few T cells against TB, which we can show by giving you a skin test. By injecting TB into your skin, you'll get a wheal. And that's the basis of the tuberculin skin test. And we'll talk about that a little further on. So immune responses go up and then they come down. This tells you a little of some of the mechanisms of turn-off. And I'm showing you an antigen-presenting cell presenting blue antigen to a T cell. And now it makes IL-2 and IL-2 receptor and all that sort of thing. And you remember this interaction of B7 with CD28. You remember that? No, please say yes, you remember that, okay? After a while, the T cell is so activated, it wants to turn off. So it makes a substance, a receptor called CTLA4, which competes with CD28 for B7. And that's one mechanism that turns the whole thing down, is the T cell starts making CTLA4, which competes with CD28 for B7. Here I'm showing you a more complicated picture. Here's an antigen-presenting cell, you see, presenting peptide inside MHC class 2 to a T cell receptor with alpha and beta chains, you see? And then here is the second signal, B7 and CD28, and the cell is now turned on. But after a while, this T cell starts making CTLA4, which competes for the B7, and now the immune response settles down, turns down. That's one mechanism of turn off of T cells. Guys, just let me interrupt myself. Why I'm telling you about this is, do you understand that if you cannot turn off immune responses, you may get autoimmune disease? You may get autoimmune disease. And I can tell you, you can take mice and you can remove their CTLA4 gene, so they cannot do this. They all get autoimmune disease. Okay? They all get, so you have to turn off immune responses. Now, another way that we turn off is that there is a programmed death signal, which is an inhibitory receptor found on cytotoxic T cells. And this interacts with a molecule called PD-L1, which is found both on tumor cells, you'll hear about that later, and on dendritic cells, you see, and macrophages, and therefore inhibits the immune response. So here's an antigen-presenting cell presenting to a T cell, you see, and now the T cell makes PD-1, which interacts with PD-L1 or L2 and turns that down. You see, it's a way of turning off. Do you also understand that if we can block turn off, your T cells will attack more and more and more, start thinking cancer more and more and more? And that's why inhibitors of this system are the latest things in cancer immunotherapy. And I just mentioned these two drugs. You don't have to remember them. These are anti-PD-1 inhibitors. We call them checkpoint inhibitors. This is what Jimmy Carter is getting for his melanoma. He's getting pembrolizumab, which is turning off the inhibitor, so his T cells are hitting the cancer. See, we'll get to that in the next few lectures. This is a second way of regulating. A third way of regulation is there is a molecule called Fas ligand, which reacts with Fas, normally present on T cells, and that causes apoptosis of the T cells. Look again, the antigen-presenting cell presenting to a T cell has got Fas on its surface, but when the T cell becomes active, it makes Fas ligand, interacts with Fas and causes apoptosis of that cell. Yeah?
Are we saying that the Fas ligand and the Fas are...
The question is, are we saying that Fas ligand and Fas are on the same T cell? The answer is yes. Your T cell has Fas, and after a while it gets so active, it says turn off. It now makes Fas ligand, which interacts with Fas and turns off. It's amazing. A fourth way of turn off is that we have in our cells, even now, we have Treg cells, T regulatory cells. These cells, Treg cells, they make two inhibitory cytokines called IL-10 and TGF-beta that suppress the T cells. They turn down T cells. So these regulatory cells, we have them. I can measure them in your blood at the moment. They're CD4 cells and CD25, just by the way. I can measure them. We all have a few, but they're not very active. But after a while, your immune response gets too much, and they say, turn off. Now, start working, you see? And they turn off by making these two inhibitory cytokines, IL-10 and TGF-beta. You see? So those are four ways, guys, that we can turn off immune responses. I hope you understand that this is a very important thing to do. You don't want to just become a mass of antibody or a mass of one kind of T cell. You've got to turn things down. You see? Now, I'm changing the topic. I'm going to come back to this a lot. I'm changing the topic for a few moments, and I want to tell you, about a concept called immunologic tolerance. And what does that mean? That means that under certain situations, there may be a lack of a response to a specific antigen. a lack of response of a specific antigen and failure to induce immunity to that antigen. And you're saying, what? You told us before, every antigen will elicit an immune response. Under certain circumstances, you do not elicit an immune response. Under certain, it's called immunologic tolerance. You see, let me just tell you a few words about it. First of all, there is a thing called self-tolerance. Do you understand that we are unresponsive to self? You don't make, under normal circumstances, antibody to your pancreas, okay? You shouldn't make an antibody to the islets of Langerhans and get diabetes, okay? Because we have self-tolerance. We've got tolerance against self, okay? You all understand that. We're not sure how that works. I'll get to it in a moment. We think it occurs during development in the thymus, that during the thymic development we have this thing called negative selection, where you do not react to antigens going through the thymus. And then we have to hypothesize that during development, every antigen in your body goes through the thymus. You know, your islets of Langerhans, and your pancreas, and your spleen, and your ovary, all these things go there, and you're turning down. Turn down, turn down, turn down. You see, that is what's called central tolerance. Now, clearly, people with autoimmune disease have lost central tolerance. For some reason, you see, they've lost central tolerance. And we know that cells that escape central tolerance, most of them, are dealt with peripherally by what we call peripheral tolerance. And there are two ways that this may occur. The one is called clonal deletion, which says that continuous exposure to an antigen causes continuous stimulation of T cells. And those T cells are so stimulated, they turn off and they die, because they are overstimulated, you see? And they probably get turned on, and then start making Fas ligand and turn the whole thing down. This is what we think. This is a hypothesis. The other thought is that maybe tolerance is caused by the failure of the B7-CD28 interaction. You see, this is a hypothesis that under certain circumstances, the B7-CD28 doesn't take place, and then the T cell is not turned on. These are just some ideas. Now, I want to tell you or tell you a thing about fetal tolerance. I told you about self-tolerance, fetal tolerance. And what fetal tolerance says is that antigens given into a fetus are treated as self. You see, are treated as self. You know that the fetus eliminates all antigens coming through it in the thymus, okay? So, here's a white mouse. Well, you take a white mouse, a mother mouse that's pregnant, okay? You open up her belly, you open up her uterus, you take out the little baby, hold it there, and you graft onto it a piece of black skin, which is a HLA different from a HLA different creature. You sew it back, you put the thing back, you tie up the uterus, you tie up the belly, and she gives birth to this, and this is what this baby looks like, you see. But for the rest of this baby's life, it is tolerant to black tissue. You can give it a kidney from the black the strain, a liver, a heart. Now, isn't that exciting? Isn't that exciting? And that is why You see, when little babies are born with congenital heart disease, horrible, they're going to die. If you can get a tissue donor, you can do a transplant of a new heart into that baby. And if you get it very early, like day 1, 2, 3, the baby treats it as tolerance, and the thing grows. You get a wonderful success rate. You see that? Whereas if you did that in older children, it's not as good. Yes?
So if a mother has an infection or a disease in her past.
Oh, isn't that interesting? A very interesting question. If a mother, if a pregnant woman has an infection, will the fetus become tolerant to that organism and then in later life not respond to it? That's what you said, right? Yeah, so that does not happen. That does not happen. I think it's a very interesting thing, but that does not happen. So fetal tolerance is just very interesting. The crux of fetal tolerance is that in fetuses, is that the word? Fetuses, tolerance is much more easy to form, you see? So you could put into, they're so amazing. On scans of the belly, you can find a child that is born with an atresia of the colon. The colon is basically a piece of string instead of being a tube. You can take, if a little baby dies somewhere else, you could take that colon, you could open the mother, take out the baby, do surgery on the baby, and transplant that, and the baby will accept it. It'll treat it as self, because in the fetus. These things very difficult to do, obviously. You can imagine. Anyway, that is what is called fetal tolerance. Now, guys, adult tolerance is very difficult to induce. In fact, we don't know how to do it. The transplant surgeons are dying for adult tolerance. You see? So, he's going to give me a kidney. How can I make myself tolerant to him so that when the kidney comes, I don't reject it? They've tried all kinds of things. They've tried giving me his white blood cells. That makes things worse. They've tried doing skin grafts on me from him, hoping when they give me the kidney, we don't know how to do tolerance in adults. You guys can think about that when you're out of medical school. Because that is the key to transplants, you see. Even today, transplantation, I'll tell you about it tomorrow, it's wonderful stuff, but it's still high mortality because of rejection and immune responses and so on. So we don't really know how to do that. Let me tell you a little about autoimmune diseases. Okay, this wide variety of diseases where we mount immune responses against self. Now, I wish I could start this talk by telling you we know the cause of autoimmune disease. We do not know it. And all I can do for you is give you some ideas of what may be important in autoimmune disease. So what it is an immunological response against self due to some loss of self-tolerance. It may be failure of negative selection in the thymus. Maybe when these organ tissue antigens were going through the thymus, the one against the joint capsule was not eliminated, and now you can make immune responses and get rheumatoid arthritis. Maybe, you see. Maybe it is failure of total immunological control. There is some lack in all these factors that I've told you about, some failure in control. And the fundamental problem is there's an imbalance between activation and control. Normally, your immune response goes up and then control down. You see? With these people, the immune response goes up against self-tissue and doesn't come down. That's what autoimmune disease is basically about. So here's a young woman, you see, who has autoimmune hemolytic anemia. She's perhaps a nurse. She finds she's tired, okay? She used to run up these steps, and now at the top she's puffy, panting a little, you see. She goes to the doctor. Hemoglobin is 8 instead of 12 or 13. And they take a look again at her red blood cells, and they're all broken up. I'll just show you this for your interest. This is the blood film of a patient with autoimmune hemolytic anemia. She is lysing these red cells into these things that we call chysons, these strangely shaped cells. You see, very typical. If I look at that in a second, I say this is autoimmune hemolytic, or this is hemolytic anemia, you see? So the question is, why is she doing this? She has made an antibody against her own red cells. That's what she's done. Those antibodies attach to the red cell, they bind complement, they burst the red cells. And we call this autoimmune hemolytic anemia. And then you're going to say, why did she do that? So all we know is there are 3 components to why people get autoimmune diseases. There's an immune regulation defect. Okay? There is genetic components, and there are environmental things like bacteria and things in the environment. Let me tell you a little about them. So these are some of the immunological factors that could give rise to autoimmunity. And number 1, the first factor I want to tell you about, is that there could be exposure of hidden antigens. Now listen. I guess every 5 years, you see in the newspaper that kids were going to school on the bus, little kids, like this, and one brought along his little homemade bow and arrow, with a little sharpened stick, and he shoots it, it hits a kid and goes through his eye. I'm not kidding you. You don't like a story. I'm telling you, once every 5 years you hear about that. Now, it's terrible. They take the child to the hospital. The mother's screaming, the father is suing, everyone is very unhappy. They talk to the doctor, will you fix it up? He says, I'm going to have to remove the eye, even though the eye could heal. Why is that? Because when you destroy the eye or other tissue, you release antigens that the body has never seen, and you make antibodies against that antigen, which hit the other eye. He could lose both eyes. He could get sympathetic ophthalmia. Sympathetic ophthalmia, which means damage to one eye, releases antigens, you make immune responses, can hit the other eye. Now, some of you have got a question. Who's going to ask the question? Yeah.
I think it's more for understanding. So when the eye is penetrated, so you're saying antigens from within the eye are the ones that, let's say, T cells have not been exposed to before. That would be the reason that it would attack the other eye because of the similarities between both eyes?
Yeah. Yes, I'll come back to you. Yeah.
Why has the body not seen your eye? Why is it that we don't have self-down?
Very good question, and I don't know that. But I think I do know. During a negative selection, the eyes were going through, they were eliminated. They were eliminated. Hold on, you're getting there. Eyes are immunologically privileged insofar as there's very little immune response in the cornea. That's why you can take a cornea from you or me and just transplant it into somebody else. But that's not this.
That's like a lot of other types of injury, like we talked about ischemic injury.
Yeah. Yes, they do. If you have a coronary thrombosis and destroy heart muscle, you develop anti-heart muscle antibodies. You see? Now, you guys haven't asked the one question. Yeah. The brain is privileged. During brain damage, you make anti-brain antibodies. Yes. Now, look, guys, this is the issue. You damage the one eye, and you make antibodies against that antigen. And you should have said to me, how do they damage the other eye? Because it's hidden. That antigen is hidden. Probably it's deep in the eye. And we don't know the answer to that, unfortunately. But please understand that this is a situation where you are releasing new antigens, making new antibodies and cell-mediated immunity that can damage the other eye. We call it sympathetic ophthalmia, you see? Now, this may happen when you get infections. We're trying to think of the cause of autoimmune diseases. See, this could happen if you get infections. We'll come back to that in a second. So that's one immunological factor. A second immunologic factor is that when you get infections, you get stimulation of lymphocytes, multiple lymphocyte clones. So a virus such as Epstein-Barr virus, EBV, stimulates B cells non-specifically. When you've got infectious glandular fever, due to EBV, all your B cells are being activated. Your B cell count goes up to the sky. The EBV is stimulating non-specifically all kinds of B cells. So can you see that maybe before a child gets diabetes, he got an infection, and now they're stimulating B cells and T cells in that case against everything, including the islets of Langerhans, you see? And then there's the question of superantigens. Do you remember superantigens? They attach to the outside of the T cell receptor and to the outside of MHC class II molecules, causing T cell activation. This is normal interaction of a T cell with MHC and peptide. Here's the superantigen. Look, it's binding to the outside of the T cell receptor and the outside of MHC class II. It's turning on cells non-specifically. Non-specifically. I told some of you, you see, these are the two major causes. The toxic shock syndrome, the tampon-induced thing, and staphylococcal food poisoning. Okay? I told some of you that every summer, including the summer, on the Cape there's a big wedding and the food stands out in the heat and the potato salad is cooking and growing staph and you eat it and next thing, everyone's off to the emergency room, you see? They get massive staphylococcal activation, and we call those superantigens. Can you see that maybe before you develop lupus, you got an infection that turned on T cells non-specifically? These are possibilities. Then there could be T cell regulation defects. I told you, you should make T regulatory cells. Maybe you don't. Maybe in some things you don't. So you don't turn down the immune response. You see? And here are some of the other regulatory mechanisms, like you don't make Treg cells. You may not make CTLA4. And I've told you how CTLA4 competes with CD28 for binding to B7. And if it's defective, the T cells will continue to be activated. Continue to be activated. I told you the mouse without CTLA4 gets autoimmune diseases. You see that? Here is, again, the PD-1 interacting with PD-L1. Let me just spend a second on this. Here's a T cell interacting with an antigen-presenting cell. There's the T cell receptor interacting with MHC class 2, and here's CD28 and B7. This is normal. This is T cell activation. T cell inhibition, the same thing, but now we have an interaction of PD1 and PDL1. It turns it off. It turns it off. Maybe in autoimmune disease this does not work. Maybe, you see. One of the control mechanisms may not work. So those are some of the immunoregulatory factors that we look at. And then let me just tell you that there are definitely genetic factors involved in autoimmunity. So we get autoimmune families. There are people where the mother's got rheumatoid arthritis, and the daughter's got Graves' disease, and the sister's got also rheumatoid. You get these in families. We don't know how it works. There is not one HLA type which says this family is going to get autoimmune disease, but there are definitely genetic components. Let me tell you about the strain of mice, just to demonstrate. It's called the NZW hybrid, New Zealand black, New Zealand white hybrid. Do you know that all of these animals, you hybridize a white with a black, all of the babies get autoimmune disease? You put together some gene, all of them die of autoimmune disease. So I'm just showing you that certainly there are genetic factors that are involved. There seems to be an increased incidence in twins. If one twin's got rheumatoid, the other has a higher incidence of rheumatoid. And there is an association of many autoimmune diseases with particular MHC types. So you know about the association of B27 with ankylosing spondylitis, or DL3 and DL4 with type 1 diabetes, or DL4 and rheumatoid. There is some genetic component, guys, but we don't know what it is. See, we don't know. Now, the next thing is environmental factors, and we have this concept of molecular mimicry. Molecular mimicry. And what I want to show you is that over here we have a streptococcus, you see here, and we make antibodies against the streptococcus. Here are the yellow antibodies, which will hit and bind to the streptococcus. That's good. That's a good thing. But in some people, some of these antibodies cross-react with heart tissue, giving a disease called rheumatic fever. In some people, these beautiful yellow antibodies that we made from the plasma cells, and blue ones, will combine not just with the strep, but with heart muscle, and that gives us rheumatic fever. Rheumatic fever. And guys, that is why it is so important when you have a child with a strep throat, you give them antibiotics. You see? And the mother will say, listen, it's getting better. He's had it for 4 days. His throat's getting a little better. Do we really need antibiotics? Absolutely. That's why we don't see much rheumatic fever in this country, thank God. It's a horrible disease, you see? Because kids with sore throats go to doctors, they do a rapid strep test. As soon as they see it's strep positive, they give antibiotics. And the rheumatic fever has declined almost to negligible because of that. And this is the reason why. Because the antibody cross-reacts. We call that molecular mimicry. Can you believe that on your heart you have the same antigen that is present on a disgusting streptococcus? Make an antibody against that tissue. I mean, it's kind of sickening thing to think about, you know. Here's a poor kid, listen to this, lovely child. He had a strep throat infection 1 week ago. Now he feels sick, he's got joint pains, fever, and a heart murmur. You listen, you hear the heart is defective, the valves are defective, and the heart gets bigger and bigger and bigger. Here's an x-ray. Just look at the size of this heart in this poor kid with rheumatic fever. You know, he's going to have to undergo surgery to fix up the valves and so on. So again, the antibody against the streptococcus attacks heart muscle. Okay? Now, there are other microbial factors. I've told you about release of hidden antigens. I've told you about molecular mimicry, about abnormal activation of lymphoid cells, like in EBV, just turning on lymphoid cells. Microbes may damage tissue, leading to release of hidden antigens. I'll tell you a story. If a dog gets a brucella infection, it's a bug, you know, it affects the testicles of the dog. And do you know what you find? A week later, anti-testicle antibody levels go up to the roof, and the dog becomes sterile. You see, the organism has released antigens, and now you've made antibodies against those antigens. Okay? In this case, it causes sterility. So a bacterial infection may damage tissue, release antigens, and now you can get autoimmune diseases. And then finally, as far as this is concerned, microbes may function as adjuvants and stimulate immune responses. Guys, an adjuvant is something that increases an immune response. I'm showing you in the first picture a kid who gets a measles vaccine. You know, he makes a little IgM and a little IgG. If you add to that measles vaccine an adjuvant, usually aluminum, you don't have to know that, just look how much bigger this immune response may be. So we don't know. A person could get an infection and in some way combine it with an adjuvant and then get a much bigger antibody response, which could cause autoimmune disease. Now, finally, just to end this, I want to add one last circle, and that is there are definitely hormonal factors involved in the development of autoimmune disease. And here I'm showing the massive increase in autoimmune diseases in women. Look at this. For rheumatoid arthritis, for polymyalgia, all of these autoimmune diseases, other than ankylosing spondylitis, which is more common in men, all these, almost all of these, are more common in women. Okay? Autoimmune. Lupus, much commoner. You see? Look at this. Most autoimmune disease more common in females. Lupus, 9-to-1. 9-to-1 ratio. You've got to wonder, what is this hormonal effect? Do you remember I told you about the New Zealand blacks and the New Zealand white? They all get autoimmune disease. And the females die when they're 9 months of age. The males live till 13 months. They don't get it as bad. Now, if you take the females, you give them male hormones, make them males, they get it only at 13 months. And if you take the males and castrate them so they become females, they get it at 9 months. There is a definite hormonal influence. Guys, we don't know what it is. We don't know exactly what that is. Now, finally, I want to tell you that autoimmune disease can be mediated by antibodies hitting tissue or by T cells attacking tissue, rejecting tissue. Look at this. In autoimmune hemolytic anemia, I told you about the nurse. It's an antibody attacking the red cells. You see? In myasthenia gravis, a disease I'll tell you about next time, antibodies attack the myoneural junctions. You care about it. But T cells are important, crucial in causing a whole variety of autoimmune diseases. Crohn's disease is due to T cells attacking the intestine. Okay? Type 1 diabetes is due to T cells attacking the islets of Langerhans. You see, later you can make antibodies, but it's T cells. Psoriasis, this horrible skin disease, T cells attacking keratinocytes in the skin. MS, T cells attacking myelin basic protein in the brain. So these are T cell mediated diseases, and then in some of these conditions, both humoral immunity is important and cell mediated, such as in rheumatoid. T cells attacking the joint, but also antibodies. You see? So here's just a list again. Activated T cells may be responsible for a number of these autoimmune diseases. All of these are primarily caused by T cells, and then secondarily autoantibody production. And that's why, just to leave you with the thought, all of these diseases are treated in the same way. Turn down the T cells, immune suppression. You see? All of these conditions to try and turn off the T cells that are attacking the normal tissue. You don't have to know this. This was from last year, a list of therapeutic monoclonal antibodies for the treatment of autoimmune disease. The commonest is the top one, which inhibits TNF activation for rheumatoid arthritis, for Crohn's, and so on. You don't have to know this, guy. You could glance at it. And then here, you don't have to know this. The commonest autoimmune diseases. When you go into practice, you will see a lot of mainly women with Graves' disease, hyperthyroidism. Those are the ones with the starry eyes, their eyes bulge. I'll tell you more about them, you see, with rheumatoid, with thyroiditis, and so on. So those are just a few things. Unfortunately, I leave you with a comment that we don't actually know the cause. What I've given you are some hints, some ideas, some thoughts. But what actually causes it is heartbreaking, you know. I run the laboratory at the Jocelyn Clinic, and I go in there and I look at the lab result. A new little child of 6, you see, complaining. He's peeing a lot. He doesn't. With type 1 diabetes, for the rest of his life, he's got to get insulin and be looked after. Where did it come from? When you ask the mother, was he sick? You know, last week she said he had a sore throat. Or yes, he had a runny tummy a week ago. And that brings the idea maybe the organisms were acting as super antigens or something like that. You know, we don't actually know. All right, so thank you all very much, and I'm seeing you again tomorrow. We're going to talk about tumor immunology and transplantation immunology. Okay, thanks.